All right, I think we'll get started today. So it's my pleasure to introduce our grand round speaker for today, Dr. Katja Kovacic, who is an assistant professor of pediatric gastroenterology at the Medical College of Wisconsin. Dr. Kovacic originally actually hails from Finland and came to the United States on a tennis scholarship to the University of California, San Diego. And she decided to stay. She went to med school at Brown University and did her residency there before coming to the Medical College of Wisconsin for her pediatric gastroenterology fellowship. There she developed an interest in functional disorders, specifically, and motility disorders, specifically functional nausea. She is currently an assistant professor and directs both the cyclic vomiting syndrome programs and the motility programs at in pediatrics at the Medical College of Wisconsin, and is currently an NIH-funded researcher working on defining nausea through brain-gut interactions. So, welcome.
Thank you, Katie. It's wonderful to be here. I will start, and several people are probably still dropping in, and that's fine. So my talk circles around functional GI disorders and functional nausea. I don't know if people have even heard about it, but I'm going to torture you a little bit with this topic because I think it's specifically important for physicians who are taking care of a broad variety of subspecialists, general pediatricians, to know really the background, what's maybe governing these disorders. And it's nice to be in Minnesota. I feel like kind of home because I'm from Finland. There's a lot of people of my origin. And if you wonder where my accent is, it's a Swedish accent. And it usually comes out when I have talks. So I have these disclosures that are not relevant to this presentation at all. So I will talk about the classification and diagnostic challenges of functional GI disorders. I will touch on a lot of the comorbidities because that may give us clues to underlying pathology. And then we'll discuss the limitations of the diagnostic testing there's really no diagnostic testing for functional GI disorders, but how do they overlap with motility disorders, and how can what testing do we have for these things? So, what are functional GI disorders, or FGIDs? So, the definition is persistent or recurrent GI symptoms caused by abnormal functioning. So, something's wrong with the software, not the hardware of the GI of the body. There is no structural or biochemical abnormality when we investigate with medical tests. These are normal. The prevalence in pediatrics, 10 to 20, in adults, even up to 30% of the general population suffer from functional GI disorders. So that means plenty of people in this room may have irritable bowel syndrome or whatnot, which is a lot. So they can be disabling, and this is when the brain and the gut are talking to each other, and they do so in an abnormal way. It's important to remember that they're not considered psychiatric disorders. We know that they correlate closely and are associated with anxiety, depression, and psychiatric problems or stress may worsen the symptoms, but we have a lot of evidence that there is abnormalities in these disorders at the level of the brain, and we'll talk about other things, but there is now good data from neuroimaging, from functional brain imaging studies, that, for example, patients with adult patients and adolescents with irritable bowel syndrome have connectivity changes in their brain. So the way that the connectivity networks in the brain communicate with each other are abnormal, very different than people without these disorders. So we can't really talk about FGIDs without mentioning the Rome 4 criteria. This is something you probably heard in medical school. And in pediatrics and adults, they were revised in 2016. And this is just a group of committees and committee experts that sit down and decide how we're going to classify them. So there's good and bad about that. So some people feel that this kind of limits our progress, our research by these clinical definitions. But I do think it's important to understand how we classify them. So we have in children 3 major groups. The most common one that you know about is the functional abdominal pain disorders. So the prototype, irritable bowel syndrome, IBS, functional dyspepsia, and we'll talk a little bit about those too. Abdominal migraine, which is episodic symptoms, similar to a migraine headache, and also a kind of a variant of cyclic vomiting syndrome. And then functional abdominal pain, NOS, which is really when you don't classify it for anything else, then you get thrown in that category. Then we have a big category of functional nausea and vomiting disorders, and that's where I'm going to focus a lot of on today. So that's cyclic vomiting syndrome, or CVS. At our center, we have a big kind of a mecca of CVS. We get referrals from all over the country, but this is a fairly common disorder that's really seen everywhere. Prevalence data show that it's almost as common in celiac disease, although it's very hard to study the prevalence of this. Functional nausea and functional vomiting, we'll talk more about that. Rumination syndrome and aerophagia are classified under this category as well. And then functional defecation disorders, you all know about functional constipation and non-retentive fecal incontinence. So, and I'm not going to talk much about those. So IBS, you may know, is recurrent abdominal pain, but it's pain related to defecation. And you may have heard from before that it's pain supposed to be relieved by defecation. That has changed, so now it's just related to belly cramping related to defecation and stooling. So that was a change in this last set of criteria. And a change in the frequency or form of stool. So you had diarrhea or constipation, or you can have a mixed pattern or alternating IBS. And also when the constipation, if there is constipation, when that is treated, there is no resolution of pain. So that's how to differentiate it from functional constipation. Then we have functional dyspepsia. So those were the first two big categories in the functional abdominal pain category. And that is really important to know a little bit about. In GI, we talk a lot about functional dyspepsia. And just to understand what that means and the kind of the origin of this and what happens, this is manifested by postprandial fullness, early satiety, and or epigastric pain or burning. And now the experts have classified two different ones: a postprandial distress syndrome, which has more of the first two symptoms there, but also very commonly nausea, bloating, and belching. Those are kind of supportive criteria. And then epigastric pain syndrome, that's when you have more of pain and burning. That's not really retrosternal, but in the upper abdomen. It's either induced or relieved by a meal, but can occur while fasting. So this is a way where Rome criteria doesn't really help us too much, I think. We put out these fairly nonspecific diagnostic criteria, and we should think of functional dyspepsia as a pain disorder that occurs with meal intake, in my opinion. And then if you read the fine line, they also kind of say it can occur while fasting. So how's that difference from an ulcer type of pain? It's not really. It's very similar, except that you do the medical workup and you have negative findings. So this is where things get pretty foggy. And what does this really mean? What are these syndromes? Why do we even classify them as different things? Is there a point to it? IBS, a lot of people get thrown into the IBS category, and it's, in my opinion, just because the research has been done there, the FDA cares about IBS, there's just so much hype around IBS, but I think some of the other functional GI disorders, perhaps even functional dyspepsia and how you can differentiate that from gastric motor problems, may be more important to really do more research in, and very, very common disorder. So I just kind of want to say it's not all about IBS. So most people don't know too much about functional dyspepsia, and that includes within the GI fields. So functional dyspepsia in adults, people have been studying these patients, and they're thought to have a stiff, non-compliant stomach. So that's done in adults, where you stick a Baristat balloon in their stomachs and you inflate it and you look at the compliance of the stomach, which is not really possible to do in children. This is invasive. But in these patients, there's at a higher volumes of balloon distension, there is increased pressure. So the graph on the bottom, you can't distend the stomach very much because it's non-compliant. So in response to a meal, that stomach doesn't accommodate food very well, and you get nausea, bloating, early satiety, fullness. So does that make sense? So that is functional dyspepsia. And we talk about it as a functional GI disorder. A lot of times think about that, how those disorders get very often thought of as you're just anxious. Well, here's a physiological problem that needs to be thought about, that something's actually happening here. Patients probably have a motor problem of their stomach, and that's where they're having the pain. And just because we can't see it on endoscopy doesn't mean it doesn't exist. So in adolescents, this has been studied a little bit, but not very well. This is a smaller study where 15 adolescents and compared to young adults underwent a nutrient satiety drink test, it's called, and they also underwent a gastric emptying breath test. And these patients were found to have higher postprandial symptoms about 30 minutes after they reached a maximum satiety. So a lot of nausea, bloating, pain after eating, kind of like similar to that. So probably because they have a non-compliant stomach. And they also had significant delay in the gastric emptying of solids. So we'll talk about that for a second. So here comes a big problem. So functional dyspepsia, and again, probably a problem with a stiff stomach and classified as a functional disorder, but the symptoms overlap enormously with a disorder called gastroparesis, and you all know what that is. That's delayed stomach emptying. So we're going to talk about gastroparesis more, but the symptoms overlap enormously. So in functional dyspepsia, patients don't generally vomit per the classic definitions, but they certainly can. And those patients, and one way of kind of differentiating them is to think about functional dyspepsia as early onset emesis after eating and lots of problems immediately. Well, gastroparesis patients have that as well, but if they vomit usually hours after eating. Okay, so early versus delayed emesis. So, and the vomit that comes up has been sitting in the stomach, it doesn't move forward, it's usually undigested food. So clinically, if you just ask these questions, you could really sort out a whole lot of things that a stomach emptying scintigraphy doesn't tell you much about. Okay, so 30%, unfortunately, where it gets difficult, 30% of functional dyspepsia patients are known to have delayed gastric emptying. So these are the symptoms: early satiety, fullness, nausea, epigastric pain, bloating, and again, delayed vomiting on undigested food. That's gastroparesis. So you could try to separate them, but it's difficult. And there are no sensitive diagnostic tests, which I'm going to talk about. So that's one thing to remember to ask. So we can't have a talk like this, in my opinion, without reviewing some physiology. So I'll torture you a little bit. We should think of the stomach as being a pressure pump, a peristaltic pump, and a grinder. Okay, so when food enters the stomach, like I mentioned, the stomach needs to kind of go blah and accommodate, fill the stomach, and that's where that compliance of the stomach should increase without an increase in pressure. And that's called the accommodation phase or the filling phase. The pressure and peristaltic pumps at this time are inhibited by vagal neurocircuits. Okay, the vagus nerve is involved in this phase. And this has to go right, otherwise you'll have symptoms. Then there's a pumping phase where there's slow tonic contraction of the gastric fundus and increased peristaltic contractions of the body. And then there is grinding and mixing of food with pepsin and gastric acid, and slow delivery of the gastric contents to the antrum. And then there's a very coordinated and kind of churning and mixing phase, and a slow emptying of some of that into the duodenum. And that slow phase of emptying is manifest as the lag phase on the stomach emptying curve. And that's becoming, so you can kind of appreciate how a lot of things are actually going on. And this is dumbed down dramatically. This is simplified. Okay, but all these coordinated events have to happen appropriately for people to empty the stomach and feel normal about eating a meal. So the lag phase, which I mentioned, is that green line. When you eat, there's effects of food consistency and density on stomach emptying, and we need to remember that as we guide our patients on dietary intervention if they have gastroparesis. And there's a way to tweak your diet so you feel better. If you eat a bunch of indigestible solids and high-calorie food, you're going to feel worse. So these patients are not the ones who should be eating raw vegetables and high-fiber bran cereal. They feel worse. So the lag phase you see here, water as a comparison empties very rapidly within almost half of all the water is gone immediately after ingestion, whereas digestible solids have this lag phase of over an hour and then empty under normal conditions within 4 hours from the stomach, and indigestible solids take longer. Same effects of higher calorie contents of foods. So chemical composition and the osmolality of foods also make a difference. So these are very important things to remember when you're going to order stomach emptying test. Think about the difference if you order a liquid stomach emptying test versus solid one. So they're going to empty completely differently from the stomach. So gastroparesis, and I jump into this because of the overlap in symptoms, is a very complex process as I shown. Normal gastric emptying involves intrinsic neurons and extrinsic control through the central and autonomic nervous system. We tend to focus on some commonly cited abnormalities, such as the interstitial cells of Cajal, the pacemakers of the stomach, and when they're abnormal, they may be. So this is from the adult diabetic literature, really, a lot of this data comes from, and they may not be applicable to children at all. This is thought to result from inflammation, activated macrophages, cytokine release, and fibrosis of the stomach and abnormal pacemaker activity that results in gastric dysrhythmias. Then we have decrease in nitric oxide synthase neurons that may be part of leading to this effective accommodation. We also have abnormal vagal motor circuits from the stomach to the brain. And that's an important pathway that we'll talk more about that may result in defective antral mixing and abnormal motor and sensory transmission to the brain. And then yet another abnormality is antropyloric discoordination. So when that antrum and pylorus, and actually the coordination of that with those pressure pumps is off, you may have gastroparesis. So it's not just the pacemaker cells, it's the signaling through the vagal nerve circuits, and it's the pylorus. So there's more attention now to pyloric abnormalities where the pylorus does not relax, and even those inflammatory pathways and inflammatory problem with loss of ICCs are actually now in adults found to be more common within the pylorus. There's more attention to this pylorus because now there's new tools like EndoFlip, where you can put a balloon and measure compliance, normally done in the esophagus, but now you can stick it in a pylorus and try to figure out how compliant that pylorus is and see who can respond to intrapyloric Botox injections. So that's a little more complicated. But as you can see, gastric emptying is very complicated. So this is a nice review by one of the fathers of neurogastroenterology, Dr. Goyal, and he kind of throws away a lot of those intrinsic pathways that I discussed, the ICCs, the pacemakers, and really thinks and focuses on that gastric emptying and gastric motor function is controlled by two parallel neural circuits, the gastric inhibitory motor circuit and the gastric excitatory vagal motor circuits. So the vagus nerve controls stomach function. We know it does. It's just difficult to know in different patients and different populations and ages which pathway is mostly involved. So I'm not going to bore you too much, but this is nice, some evidence of how the brainstem controls gastric function. And this is from a rat brainstem where there's labeling of the vagus nerve, vagal pathways, and there's intense labeling of the NTS, the nucleus tractus solitarius, the DMV, the dorsal motor nucleus of the vagus. They're closely close to each other in the brainstem. These are kind of the vomiting centers, and the nucleus accumbens. But this is a schematic of how afferent vagal pathways send signaling, visceral signals from the stomach to the brain, and they use glutamate as a neurotransmitter, and these two brain areas communicate. They're close with each other. And then there's efferent vagal pathways. These are preganglionic cholinergic neurons that send signals to postganglionic. This gets boring, but they are either excitatory, releasing acetylcholine, so these are vagal parasympathetic signals, or they're inhibitory, non-adrenergic, non-cholinergic. Does that make sense? So we can see how the vagus nerve is really, and vagus, again, parasympathetic nervous system, is influencing stomach function. So how do we test these problems? Well, we'll talk about here, what do we really have? The gold standard, as you may know, is a 4-hour nuclear scintigraphy scan. This is a solid gastric emptying breath test where a meal, an egg and a toast, is radio-labeled with technetium, and regions of interest are generated, and results are expressed as the percentage of retention in the stomach at various time points. So what's considered delayed based on some poor evidence is 90% retention at 1 hour, 60 at 2 hours, or mainly over 10% retention of this meal at 4 hours. Okay, so over 10% at 4 hours. So where does this come from? Well, it comes from a group of experts sitting down and deciding in 2008 the consensus recommendation for scintigraphy and for how to evaluate stomach motor function and gastroparesis. There was a lot of variation in institutions, at what time points this was measured, how it was different meals, how the results were reported. Should it be a 2 hour? Should it be a 4 hour? People performing liquid gastric emptying scans. So they set these consensus recommendations, which is good, so that all institutions would perform the same thing, and that research would be focused on same protocols. So the recommendations is to perform a 4-hour solid, low-fat, egg white meal. It's called a Tugas meal, and they should be consuming it within 10 minutes. There needs to be considerations with age, gender, BMI, drugs. You're supposed to stop prokinetics and probably any meds that can influence your central nervous system and autonomic nervous system. So 2 to 3 days before the test, that may often get forgotten about. The menstrual cycle, this paper talks about how a stomach emptying scan should preferably be performed in the first phase of the menstrual cycle, within the first week, and not in the second. In the luteal phase, there's evidence with all the hormonal changes that women have delayed stomach emptying. So there's also large influences of glycemic control, less applicable in children, but most of these things don't get considered. Okay, in our place, we don't think about this. I think a lot of institutions still don't even run the 4-hour solid test. And it's important that you probably talk and figure out what's done at your center. When I did that at our center, and I asked the nuclear techs, how come these children who say they can't eat anything and they're puking and they need feeding tubes are able to eat your egg and toast just fine? And they're not saying on the report that they're puking it up majority of the time. Sometimes it happens, but not very often. And they said, oh, we give them a little less, or the younger ones for sure, we just give them half of the meal. Oh, wow. So I was kind of speechless, because this has been determined at the higher up levels. This is how you need to perform this test. Most major institutions should be doing it, and it's being altered without our knowledge. So we are giving the same test meal to kids. That's another problem, unless we alter it. We have no norms, okay? So we have no idea what healthy kids do with this test? So that's my main point. So when you order a gastric emptying scan and it comes back as normal, think about your 10-year-old girl's little stomach, about this size, can get maybe is compared to a 60-year-old man's that's this big. And that's what your results are saying. So when I order a stomach emptying test, I talk to the family. This is actually a junk test, but if we really want to try to pick up very delayed stomach emptying, maybe we should do it. There's ways to say that differently, but it's a 4-hour test, so they'll miss a whole day of school for this junk test, okay? So you need to make it clear for that family that if you get a result that's normal, that hasn't really ruled it out. That's a little bit my own opinion and my stance on this, but we are now leading some large gastroparesis efforts within pediatrics and trying to figure out if we can establish some consensus recommendations for children, but it's going to be very hard without research. So the biggest problem here is that we can't put 100 healthy kids through this test because it involves radiation. So that's why we don't have pediatric norms. We're probably not going to have it. So we need to look outside of this nuclear scan and do research with other tests, and those things are coming. So I just want to hone down that when you see in a patient chart that where you feel like maybe they have delayed stomach emptying, they do better with an NJ, and that might be a better test to put an NJ in, a little invasive, but they can tell you if patients have a stomach problem. When you see a normal test in the chart, don't automatically assume that they don't have gastroparesis. Tons and tons of disabled patients thrown into rehab and diagnosed with psych disorders have had a normal test, and they're so surprised when I tell them they've seen a million different specialists, and they are so surprised to learn that we haven't ruled it out yet. Well, I was told that this, so it makes you feel bad, and it makes all of us look kind of bad that we are hanging our hats on on such a test. All right, hopefully I made that pretty clear. So what's the role of other gastric motor abnormalities? There may be some other ones, as I hinted at. So again, adult data to diagnose children is inappropriate. So in adults, they're now expanding this a little bit, and it's interesting. So I'm just going to quickly show that in scintigraphy, now there is a way to measure intragastric meal distribution. It's not been done, unfortunately, in kids yet, but they are able to, in response to a meal, look at fundic accommodation and dynamic antral contractility. So you give a meal, you look at time of contraction, so a dynamic test using old methods and with old scintigraphy methods and applying some more novel technology. If you look at when there's ingestion of the meal, it distributes more towards the fundus of the stomach early on. In B, the food immediately after the meal just jumps down into the antrum. And here, this is what potentially patients with functional dyspepsia do. So there's a problem here, and no other tests have really been able to identify this before. So we can get a sense of an impaired intragastric meal distribution, and in these adult studies, this has been associated with early satiety, so they're able to then classify different symptoms in relation to different abnormalities. Proximal retention, more associated with reflux, global retention of the meal, more vomiting. So this is a little bit exciting. So interestingly, 90% of patients with normal gastric emptying had abnormal intragastric meal distribution. So a fifth of patients who had normal scintigraphies, again, what does that mean? Well, these are at least adults where we have a little bit of norms, but they had an abnormal distribution of the meal after eating. So perhaps this provides some new diagnostic information on gastric dysmotility. So this is a fairly exciting test that's unfortunately still just in research, but I'm using it at our center, and there's a few other pediatric centers. The gastric emptying breath test, or we call it GEBT, uses a carbon-13 labeled substrate in most cases, spirulina algae. So you actually have to, spirulina is an algae that's green. You have to eat green eggs, which is usually the biggest problem for children, but most of them can do it. It relies on having normal duodenal absorption, liver and lung function, because this, after labeling this meal, there's portal transfer of the substrate to the liver and subsequent excretion of C13 in the breath, and a delay in the delivery of this carbon-13 out in the breath is signifies a delay in the transit from the stomach to the duodenum. So this is the rate-limiting step. And this performs very well. It seems almost too simple, but there's been a lot of research on different breath tests for decades. And this is shown about 80% correlation with scintigraphy in adults, but in a smaller pediatric study has performed quite well as well also. So it's a standardized meal that has a long shelf life, so very easy to do. It gives this full 4-hour emptying profile. It's now FDA approved in adults, and it's very simple. You can even do it in your office, and there's no radiation. So we have performed 100 healthy controls at our center, and we are doing it in sick patients now in my nausea clinical trials. And many of them have had scintigraphy, many have had a normal scintigraphy and an abnormal breath test. So we're gonna hopefully get some curves in healthy kids, but this is still based on adults. These results here are expressed as that carbon-13 excretion. So the dotted line shows if you're under the dotted line, there's delay. So this patient is a 16-year-old teenage girl. Came after seeing many specialists, several centers, and was told that because her nuclear scintigraphy for gastroparesis was normal, the patient had been told she cannot have gastroparesis. Okay, so there was all kinds of signs of gastroparesis. I mean, she was vomiting undigested food. She wasn't handling it. She was been put in a pain rehab program. She was put on several antidepressants. Nothing was working. Upon further questioning, she also had dizziness, postural dizziness, brain fog, chronic fatigue, you name it. When she underwent an autonomic test, a full autonomic test that's done at our center, she was weaned off these meds and she felt better. Okay, so she had an autonomic dysfunction and she had gastroparesis. So note that at 4 hours, this actually turns normal. So we don't know. There's some data that scintigraphy is that 4-hour mark is the most important, but why is that? We don't know. So maybe if we only looked at the 4-hour profile, and which was probably done with the scintigraphy, this patient had a normal test. There's nothing to say that having delayed emptying at the earlier time points is not abnormal. So, of course, you're going to be sick and feel yucky about eating if you have this type of curve. So most patients healthy controls typically fall way above this. So again, we're creating healthy control data in about 100 kids now. So this is potentially an exciting test that's non-invasive. So, some words about autonomic dysfunction. You probably seen these patients. They're complicated, they're sick, they're disabled. But how do they relate to stomach emptying or stomach motor function problems? Sadly, in the literature, not at all. But what do we have? We have retrospective reviews only. And we found that that data shows that there's abnormal stomach emptying in about a third of these patients. And there's been a complete lack of correlation between gastroparesis and POTS. And even more often in adult literature, there's some accelerated emptying in these patients. Perhaps they have an intragastric meal distribution that's abnormal. Well, something's going on. But sadly, we don't have pediatric norms or accurate tests to diagnose gastroparesis. We don't have very validated tests for autonomic dysfunction either. So I just want to mention this because you see tons of patients with the features of the one I just mentioned where they overlap. They have some kind of gastric motor function problem and they have an autonomic disorder, often undiagnosed for years because we just don't ask all those multi-system questions. So by relying on poorly performing tests to rule out gastroparesis, we may be really doing patients a disservice. So if you don't know the definition of POTS, I think it's important to know that's the most common autonomic disorder. There's a group of them, and they are often treated very much the same way, although autonomic experts can sometimes tweak treatment a little bit differently depending on the abnormality. This is defined in children as an increase of 40 beats per minute in the first 10 minutes of a tilt table test. So that's a motorized tilt test where a lot of cardiology groups, I don't know how it's done here, puts the patient up slowly and measures blood pressure, heart rate, and there needs to be orthostatic symptoms with it. Dizziness, lightheadedness, palpitations, nausea when those children get tilted up. And there should not be a sustained decrease in blood pressure. So that's what we often get wrong. So we call everything POTS, and the patients who have drops in the blood pressure, they may have certainly a vasovagal syncope, a very orthostatic hypotension. Those can actually be treated differently because you can give them things like midodrine or alpha agonists that drive their blood pressure. So it is important to understand a little bit of what's going on here. But unfortunately, this is also a group of experts sitting down and deciding this, okay? So a teenager who have all these symptoms, I get a lot of them who may have a heart rate elevation of 35, and they have all the symptoms in the world, and they get normal test. So there has to be a cutoff, right? But we don't have norms for this test either. It has not been validated. So there's the problem, right? So sometimes I think that just looking for the symptoms and really honing this out clinically might be just as good. A word about anxiety, depression. This is often on our minds, right? When we see these patients, they have an abnormal autonomic nervous system. So their fight or flight is revved up. Their parasympathetic and sympathetic nervous system are essentially out of whack, and they suffer because that high sympathetic drive. They are anxious. They're going to be anxious. It's part of the disease. If you talk to people who are adults, some medical professionals have this disorder, they're anxious. But where do we draw the line in these patients where psychiatric disorders, medicalization takes over? So that's where we have to have good psychologists to evaluate them. We often maybe can't do it ourselves, but to blow them all off as psychiatric problems is a little bit wrong. So now it's when you're falling asleep. I'm going to just quickly bring in a case of a 16-year-old female with daily abdominal pain and constant nausea. Nausea is her main problem. She does wake up with belly discomfort, worse with food intake, bloating, early satiety, fullness with eating. She had an Arnold Chiari decompression surgery. She's had progressive weight loss. She's been evaluated by, you name it, 10 or 15 subspecialists, many different hospitals, still no diagnosis except for functional GI disorder and anxiety. She's been put on numerous antidepressants. She hallucinated with Prozac and other antidepressants, and then she was told that was in her head as well. So this is sad, but that brings us to functional nausea, one of those difficult to figure out disorders that's part of functional nausea and vomiting disorders. And before I jump into that, I have to have a slide about CVS, okay? I'm vomiting it. This is a disease that you will make a difference if you notice it, okay? It is clinically all clear. We run a CVS program. There's very much a more attention and sort of more awareness of this disorder recently. Primary care doctors are doing a wonderful job finding them, but also parents. Many are self-referrals to us. They Google this, and the parents actually figure this out majority of the time. And that's sad. We diagnose them. They come to our ERs, and they may come once or twice a year to the ER and have intermittent attacks. And how can we really differentiate this from a virus unless we really dig into these patients, see if they have a migraine family history, which is present in 80% of them. But a lot of families come to me and they say, it took 5 years to figure this out. We didn't really figure it out ourselves. We were told we have viruses. We were in the ER, got IV fluids, were sent home. We didn't figure out that kids don't get so many viruses until we have the second child who was normal. So the definition is that 3 attacks in about a 6-month period. This is set out by the pediatric GI community rather than the Rome criteria. So this is actually a little bit better diagnostic criteria. So the episodes of nausea vomiting can last for 1 hour to 10 days. They are severe, relentless vomiting. So differentiating it from gastroparesis is that these patients, they empty their stomach, they continue to be sick. They're just nauseous. Younger kids stick their hands in their mouth to try to get some relief, but they don't get relief until you sedate them. So Benadryl can be used at home and Ativan in the ER and hospital, but this is a disabling condition. I just want you to know about it. I think you probably already do, but the classic thing is that 98% have stereotypical episodes. So the parents describe them as completely the same, and then they wake up. Sometimes they crawl around in our office and just vomit. They're like so lethargic. Some parents describe it as a conscious coma. And then they get some rest, and a few hours later, they just wake up and say, "Can I eat? Can I eat?" And it's almost like chilling to see the difference. So they're well in between, at least 1 week apart. Another thing is that we think they need to be vomiting intensely. So those are the reasons for these criteria. They should be vomiting every 15 minutes. Not always. They don't always follow strictly these criteria, but it's pretty darn close. And this can be diagnosed. This should be diagnosed clinically. Okay, so let's switch back to functional nausea. This is defined as a predominant symptom of bothersome nausea 2 times per week at least, and generally not related to meals or associated vomiting. So what is this really? So this Rome experts have decided that they believe that the absence of pain in these disorders suggests that they should not be included as part of functional dyspepsia. So these patients have nausea, they have functional disorders, we don't know anything about them. That's kind of what this says. Does this really exist? So we started studying this at our center with some of my mentors. We just see so many of these patients. So what is it? So we really don't have any literature. Sadly, several of these are papers. Many are retrospective, but almost every paper on this actually describes patients who have pain. So I don't know that you can separate it and just say that these patients don't have pain. So I have set out to study them. We are now, through my NIH-funded study, bringing in patients just with nausea, and their thought is to just have this functional nausea. But I can tell you, most of them will have some pain. You just can't separate things in the functional world like this. So we have shown that they're disabled. So this is a prospective study that we just published. Their quality of life is poor and worse in those patients without nausea. They're disabled both by child and parent report, kind of. The p-value is borderline there. So they have comorbid symptoms. This is probably why they're so disabled. The nausea patients have dizziness. They have concentrating difficulties, the brain fog. They have chronic fatigue. They have sleep problems. So what's happening? So what do they have? Do they have autonomic dysfunction? Maybe they do. And do we ask these questions? I think a lot of us don't. Do they have anxiety, depression? Well, they certainly can. So back to that case, this patient has constipation, somewhat controlled laxative. She has regurgitation and heartburn. She has postural dizziness, and she has tingling in the extremities and flushing. She has migraines. She has muscle, and she has joint pains. She has chronic fatigue and sleep disturbances and brain fog, but she has no anxiety. That's per report. I think she does, but probably more manifestation of the long search of years of not figuring out what's wrong with her. So her autonomic test was positive, showed POTS and a mild autonomic neuropathy, and that's a sweat output test that it's done. And these patients who have several abnormalities tend to be worse. They have a lot of things going on and very difficult to treat. But what does she really have? Does she have something? How can she have every system under the sun involved? So she also had poor wound healing, and her joints were popping out of place. So any thoughts on that? Yes. Oh, somebody knows EDS. Good. She's got EDS. That's what she's got. So, wow, this is something that every doctor who sees general patients, rheumatologists, any specialty needs to know about. You probably do, but I think in GI we don't ask the questions. In our clinical trials, we're now evaluating for EDS or Ehlers-Danlos syndrome. Poorly recognized disorder diagnosis is sometimes delayed for a decade. And the symptoms are not even subtle. I mean, joints are popping out. You can see it from across the room sometimes. There's a tall, slender mom who's got a wingspan like this. They're marfanoid. It's not always that evident. Or a mom who sits with her, her feet curl like in a weird spot. Sometimes I just walk in and say, oh, another Ehlers-Danlos patient. And these patients are suffering. They're called the zebras of medicine because they are silent sufferers. They look normal, okay, but they have almost every system involved. But there's a spectrum. You can just have migraines, some GIs, some constipation, and you're fine. But there's a spectrum of disabling disease. So it's a hereditary disorder of connective tissue. 13 different forms. There's a lot of I'm not a geneticist, so I'm not going to talk too much about this, but the geneticist is the best one, and the rheumatologist to evaluate these patients. So there's a problem with the collagen that's kind of everywhere. It's in our GI tract, in our skin, in our eyes, other organs. There is joint hypermobility, so you should assess for this in GI patients, and skin extensibility and tissue fragility. So the vascular form is best described. It's a rare form, but it can lead to severe complications. So if you find that a patient is hypermobile and you really are going to do invasive procedures, it's always worth asking a little extra questions. Do they have easy bruising, bleeding, and vascular form? I've never seen, but that can be tested for. People have died from procedures having this form. The hypermobile form is the one I'm really talking about. It's a highly under-recognized. It's the subtle ones that patients have joint hypermobility. And unfortunately, there is no clear genetic mutation. There's no test for this. So that's where we have to sort this out clinically and look at things like this is a nice website, by the way, to give to patients and for yourself. But you look at the Beighton score. It's been a classic way of measuring it. So these are the extremes of connective tissue disorder. Not everybody can do this, and it's often a lot more subtle than this. But the Beighton score is looking at the elbows, the knees, and certain joints, and gives a score up to 9. And traditionally, a score of 4 have been a cutoff. Now, in the latest consensus is that 5, so they become stricter with the clinical diagnosis of this. And I don't know if it's good or bad, because now less patients are getting this diagnosis, but there's definitely a spectrum. There's something called connective tissue disorder spectrum that fall kind of in the gray line. They don't have all the criteria, and they may have a Beighton of like 4. And there might really be something very abnormal with those too. We just need more research on this. You can find this complete classification on that website, and you can easily go through this. It looks pretty intense, but you're looking for high palate, dental crowding, tissue fragility, things like hernias, scarring, and you can score them still very quickly. So autonomic disorders and EDS. I'm getting to the end soon. So there's a lot written about this, more so in adults, but we published on the relationship between EDS and functional GI disorders. There's quite a lot of literature on abnormalities on the autonomic nervous system in EDS patients. And in adults, even more so in adults, on the GI problems in these patients. It's disabling. This is a survey of many hundreds of patients across many institutions, and 96% of them had GI symptoms. That's a lot. So as GI doctors, we don't usually ask a lot of these questions, but you may ask, what difference does it make? Well, if you see these patients and the suffering they go through, even if it doesn't make any difference, we have no treatment for these disorders, having an underlying cause, it's a huge amount of relief for most families. That's how I see it making a difference. So to our data, this gets a little dicey, but I'm doing heart rate variability testing on a lot of the patients who come into our clinical trials. And we've already looked at our past data. I'm working with somebody who is an expert in HRV, and Dr. Stephen Porges, and he has defined some metrics such as the RSA, which is a measure which is a rhythmic fluctuation in the heart rate that takes into account the spontaneous breathing. It is kind of the primary component of heart rate, of high-frequency heart rate variability, which is the parasympathetic tone of your body. So this is a measure of the cardiac vagal regulation of your heart, vagal regulation of your heart. It's kind of provides this dynamic measure of the efferent output of the ventral vagal complex. So you can think of it as a vagal brake on the heart. So it's a pretty sensitive index of how the vagus nerve and your parasympathetic system kind of works, sophisticated to slow down the heart rate upon posture challenge, and other things like even a meal ingestion in some patients can cause distress, and the system needs to be in balance. So I'm not going to get into all the details, but I want to show that higher Biden scores, and this is unpublished data, is associated with a lower vagal tone, especially in the supine position. So in purple there in the supine positions, patients with higher Bidens had a lower vagal tone. So something that supports, and this is in children, this is the first data we have on this in children, supports those adult findings that the autonomic nervous system is wacko here. So again, so we have a little complicated, but we've also defined a new metric called the Vagal Efficiency, which is essentially an index of how your heart rate changes with increases and decreases in that vagal tone. So how does that vagal brake work to regulate the heart rate? So patients with high vagal efficiency is a good thing, and low is a bad thing. So we now see, looking at our past data, that those patients with high Biden scores, and when the cutoff is 4, it made a big difference. So low vagal efficiency was dramatically found in those with high Biden scores. So hypermobile patients have a problem with the efficiency of the vagal brake in regulating the heart rate. So that means they probably have postural dizziness and issues with adjusting to normal stressors in daily life. And then, so think about functional GI disorders and anxiety, how these patients may be having trouble with body hemostasis is what I'm trying to show here. So we're hoping to publish this. So what is functional nausea? I don't know yet. We're trying to figure this out. Is it gastroparesis? Is it functional dyspepsia? Is it a variant of cyclic vomiting syndrome or migraine disorder? Is it autonomic dysfunction? Well, that's kind of where our data is leaning. And do a lot of the patients have EDS? Yes, they do. And where does psychiatric disorders come in? We don't know yet, but we're looking at this in a clinical trial that's defining adolescent nausea. So far, we're about halfway. We're looking at enrolling 100 subjects. So far, a third have gastroparesis based on that breath test. Many have had a normal scintigraphy. Half so far have abnormal autonomic function tests. Unfortunately, it's not done in everybody because it's a tedious test. And 40% met criteria for EDS with this new stricter classification. So that's a lot. And we're really trying to enroll, this is a tertiary care center that's kind of a neurogastro center, but we're trying to enroll garden variety nausea. But it appears not to be a lot of garden variety nausea. A lot of them have an autonomic dysfunction, and that's a tilt table test. So I think I've shown that how the brain is influencing GI function and how the autonomic nervous system is kind of the mediator of this. I tried to hone down that gastric dysfunction is not always gastroparesis. There's other gastric motor abnormalities involved, and how that brainstem really controls stomach motor function and the sensory function. So how do we treat it? Well, we typically use prokinetics, we use meds that work solely on the stomach, and then we use antidepressants that amitriptyline works on 12, 13 different receptors in your brain. Some form of neuromodulation seems to be more effective, but how do you do it non-invasively? So quickly, IBS, for example, often looked at just the gut. Treat the constipation, treat the diarrhea, and you'll be fine. Doesn't work that well. We know that we have to use CBT, hypnosis, affect those higher brain centers, and that's more effective. But now we have a way of non-invasively stimulate these nervous systems. So this is part of the same clinical trial. All these patients with nausea actually go through auricular neurostimulation therapy, and we've already shown and published in the Lancet 2 years ago that this non-invasive ear device is effective over placebo in a randomized trial with adolescent functional abdominal pain. Many had IBS, but they had a variety of functional pain disorders. So we think we stimulate several cranial nerves, the vagus, the trigeminal, maybe facial nerve in the ear, and those tracing and animal studies show that those nerves closely connect to the brainstem areas that I reviewed. So this therapy is very exciting. I'm a little bit super excited about it because now it's been FDA approved based on our initial research. It's the first FDA approved therapy for functional GI disorders, and it was specifically approved for adolescents with IBS. And again, we just care about IBS. It really should have been approved for any, but now at least we have some potential novel therapy that's non-invasive and non-pharmacological. Our preliminary data already shows that abnormal autonomic function actually is associated with pain reduction, more so in the patients in the treatment arm. So patients with autonomic disorder appears to be doing particularly well. We haven't published this yet, but some of this data is coming and hoping to get this out soon. So in summary, functional GI disorders involves an abnormal brain-gut axis signaling. Brainstem really probably mediates gastric function via vagal pathways, more extent that we realize. Current tests do not capture the spectrum of gastric motor function abnormalities at all. Gastric scintigraphy and a nuclear scan, if you do it right with a 4-hour solid meal, but really you should know the limitations of it. And you may think about not doing it at all and trying to diagnose this clinically. Comorbid symptoms such as multisystem, autonomic symptoms, joint pains may give clue to underlying pathology such as ANS or disorders or EDS. Assess for this if you can, clinically. If you can't, if you don't have the tilt table, you should really be looking for it clinically and assess for joint hypermobility if you can. Functional nausea may be a manifestation of autonomic nervous system imbalance. And vagal efficiency during posture challenge may actually be an index of joint hypermobility. So we have some exciting data coming out here. So I think that suboptimal autonomic regulation really may be an underlying mechanism that governs these disorders and a lot of comorbidities. And thanks to my mentors at the medical college and my vagal nerve guys, Dr. Porges and his collaborator, Dr. Kovacic, are really the brains behind these experiments. So a little longer, sorry, but happy to answer questions. Thank you. Somebody.
Good morning. My name is Matthew Armfield, and I work with pain patients here, and I see a lot of patients with functional pain disorders, functional abdominal pain, chronic daily headaches. A lot of the treatment that I've put them through is trying to get them back to leading a normal lifestyle and really pushing through the pain to retrain their brain to understand that what they're experiencing is not a harmful, painful experience. Can you talk about any sort of lifestyle modification changes that you ask for these patients?
What modification changes?
Lifestyle changes?
Yeah. So this is, one of the cornerstones of therapy is seeing now how we use the ear stimulation and how these patients are just disabled on so many drugs. I don't even see pharmacologic therapy as a good solution anymore. I think it makes them worse unless you can really, really identify depression and treat that, right? But you have to be really careful. So lifestyle changes. So the boot camps work the best. The rehab centers, we don't have that at our centers. We send them out to Mayo and Cincy to the pain programs. I think they really do work. So there is this disabled state that starts with medicalization. It continues with the environment of the parent, that you have to really intervene. And I think it's hard to intervene. Where we come in is a little too late. So a lot of people starting to talk about, why don't we intervene in the PMD office? Like, that's where we need to catch them. Because when you have that talk about, I think you can do a lot as you evaluate these patients by just having education sessions. Sometimes see patients not come back after just telling them this is benign and this is fine, and you have parents who really follow the steps, get the kids out of bed, get them to school, start exercising, but intervening as early as possible, and just talking to the child about, like, this is not dangerous, you're not going to die. Even POTS and those autonomic disorders, they really think they're going to die. Like, you look at their faces when you say, you think you're going to die? Or you think, yeah, they think so. They think that this is serious. They had brain MRIs, they had a million gazillion testing. So I think just education, talking to them, but catching them early, and everything you can do on your own, what the rehab center does, is reduce pharmacotherapy and just good sleep. Cyclic vomiting patients, you can make a huge difference if you get them to sleep regularly. Good sleep, and like any migraine patient, lifestyle, exercise. Exercise actually is bigger than we think for these patients, especially autonomic patients.
It's 8:30. If you have any further questions, come to the front to see her. Thank you.
Thank you.